This module should help church leaders increase their understanding of controlling infectious diseases. My name's Dr. Bridget Sterling, and today we're going to help you to understand and identify the risk from infections, increase your understanding of how a pathogen moves from one person to another, identify ways to stop disease transmission, consider ways that church policies, procedures, and practice can reduce risk, and work through a case study with an example from a church setting. Let's begin by talking about what an infection actually is. Of course, we know that the world is teeming with living and non-living microorganisms, and these are just things that are too small to see. And our human bodies have microorganisms in them, inside and out, and in fact, we wouldn't be able to be healthy, active, vibrant human beings without them. They're in our environment, they're everywhere. So if you're touching a computer right now, you can be sure that it's absolutely chock-a-block full of microorganisms, and most of them are not harmful. But some of them are. So we refer to microorganisms that are harmful as pathogens. Human immune systems are pretty good actually at stopping pathogens from spreading inside of your body. So every day you have millions of different microorganisms that you're encountering, and some of them are pathogens that would cause illness, and your immune system recognizes them, attacks them, and neutralizes them. But sometimes that doesn't happen. So whenever we have a case of an infection, which is when there is a pathogen that's come into your body and taken hold, it is multiplying inside your body, and it is becoming more and more prevalent inside of you, then that's what we consider an infection. And in epidemiology, we like to think of infection moving from one person to another in the metaphor of a chain, and all the links in the chain are all the things that need to happen in order for an infection to move from one person to another. So we also like to think of how we can break any of those chains, links in the chain, in order to stop an infection from moving from one person to another. So if any of these links that we're going to be talking about is missing, then we can actually prevent a new infection. So understanding the chain helps to prevent opportunities for that transmission to occur and increases our chances of breaking the chain. So there's lots of different kinds of disease-causing microorganisms. So pathogens might be viruses or bacteria. They might be fungi or parasites. In the case of SARS-CoV-2, which is the virus that causes COVID-19, we are dealing with a virus that is a small piece of genetic material, essentially, just bits of protein pulled together. And that little ball of protein is actually not able to make any new viruses outside of a body. So they can't live on their own. And they're not things like bacteria that are treated with antibiotics. They're a different organism altogether that we need to consider. Sometimes we talk about viruses as if they're alive, or we talk about killing them. That's not actually quite true, because viruses aren't alive. Viruses are small little organisms that require another being in order to exist. So we do have vaccines for a number of different viruses. So you may have had the measles vaccine, for example. If you've had the measles vaccine, it doesn't matter how many people you come into contact with measles, you likely will not get the disease. There's also some antiviral medications, like for people with HIV, that people can take. And there are now vaccines that protect many people from acquiring COVID-19. However, one of the things I'm sure you've been hearing about lately is the idea of a variant. So as viruses come into the human body and inject their genetic material into your cells, they use your cells to create new viruses. They essentially make little virus-producing factories inside your body by using your own cells. As they do that, and as the RNA from the virus is injected in, and it makes a copy of itself, it often makes mistakes. And those mistakes in science are called mutations. And over time, a number of different mutations on important parts of the viral protein make changes that put us at risk of different outcomes. And when we have that many different mutations, we then call the virus a new variant. So, for example, on one of the new variants of concern that we have in our world circulating today, there are 19 different mutations on the little spike protein of the SARS-CoV-2 virus. And so 19 different mutations had to take place in order for that virus to be different enough for us to call it a new variant. So right now, we are concerned that these new variants may have significant changes that are important to public health and important to church leaders, because they may change the severity of disease in people. They may change the transmissibility or the ability of the virus to be detected by all of the tests that we have right now. We also are concerned about these variants because they may not respond to medicines that we're using. And they could change the effectiveness of these vaccines that have been so hard fought for. So we're concerned about variants because essentially they create whole new pandemics of disease. So we're watching, we're praying, we're thinking, we're concerned, but we're not afraid. And incidentally, once you know how to confront a specific virus, in order to confront its variants, it's more about pivoting rather than starting from scratch. So anybody that kind of feels discouraged by it, that's understandable, but it's not about starting again. It's about just pivoting towards something a little bit different. So let's move on to reservoirs of disease. Now that we've thought about agents or infection agents or pathogens, now we want to think in epidemiology, the second link in the chain that we might want to expose some cracks in and make some prevention happen is in the reservoirs of disease. And so I've given this example of this very cute little rodent here. Well, unfortunately, rodents can be terrible reservoirs of disease. And that means that that's a place in nature where the pathogen exists. And then when the animal or whatever it is comes into contact with humans, then unfortunately we can have an outbreak of disease or a new crossover of a disease from an animal into a human. So for SARS-CoV-2, the natural reservoir is still unknown, but there have been documented cases of animals, such as minks, that have been both infected by and infected humans with COVID-19. So we know that there are certainly crossovers happening, which is not a good thing. We do not want to see that. We don't want to see animals, even pets, being infected, because a virus going into an animal and then back into a human can increase the chances of mutation and increase the chances of variants. So we don't want to see that. And there is a strong zoonotic link, meaning that animals are usually where we see humans coming into contact with diseases. So for example, the vector that we might see in a mosquito might cause West Nile. We may have a bat bite somebody. Bats can carry rabies. We might have something like a chicken that we're eating that has salmonella, and then we end up getting infected with that. So we see that there is a lot of connection between animals and humans in as far as new diseases emerging. But what about COVID-19? We don't actually know the origin. It's not been clearly defined. It's possibly bats that we would have had that crossover from. But really that doesn't matter. Well, it doesn't for the future, but for right now and for church leaders it doesn't. Because what we really want to be concerned about is the transmission between humans and animals. So really the main reservoir of infection for COVID-19, the virus that causes COVID-19, is infected humans and the air that they breathe and the things that their hands and mucus touch. So we can talk about, if we consider humans as being the reservoir, how we can interfere with that reservoir so that we don't have as much transmission going on. Well, we can absolutely reduce the reservoir on an individual's body. And we can do that by encouraging them to wear some kind of a facial covering, because if they are infected with the disease, they are the reservoir of infection. If we can ask them to protect us by wearing a mask, that would be really important. They may also limit the use of things that aren't regularly washed or easily washed. They may watch the length of their nails, and they may just really encourage people to be clean, to bath and shower frequently, and to make sure that things like that people maybe don't usually wash, like their handbags, or jackets, that they're kept as clean as possible. Because if that person becomes a reservoir of infection by them traveling around with things that are unclean or unwashed, and then being in the presence of others and touching things, can help to spread a virus or a pathogen of any kind. So what do we know about COVID-19 and the human reservoir? We said before that they're not living. Viruses aren't living. They need a cell to replicate. They can't just decide to replicate on their own. And so when the virus enters a person's nose or eyes or mouth, so the mucous membranes, it has to attach itself to a host cell and then inject its genetic material or RNA into it. Then the infected cell uses the SARS-CoV-2 RNA to make replicas of its own viral genome. And each infected cell can release millions of copies of the virus. So you see cell die-off because the cells themselves are being used as these little factories. And of course, they're absolutely useless once they're finished creating all of these virus. And so you'll see some cell death. And in the case of SARS-CoV-2, we know that it isn't really a respiratory disease. It is a respiratory disease, but it's also a blood disease, a brain disease, a vascular disease, a kidney disease. So we have so many different places that this particular virus can affect. So what is the period of transmissibility? We would say that the incubation period for this particular virus is between 3 and 7 days. And what that means is that if I come into contact with somebody today, and it is the first of the month, then for the first, the second, the third day, we're probably just now incubating that virus. So that's the time that those cells are creating new virus. They're replicating in me. They're probably not at the point where they can exit my body and become infectious to you. But around, between 3 and 7 days, up to 7 days is when my body is still incubating that particular virus. So probably not infectious, and I probably wouldn't be able to be picked up by an antibody test. Like if you tried to see if my blood was producing antibodies to the virus, that likely would not happen. And also even just from a nasal swab, you probably wouldn't find any virus shedding from my nasal cavities for the first week after I've been exposed. But it is possible to detect in some people between 1 and 3 days before symptoms occur. So before I start to get the virus actually is making me sick, it's increasing, my body's fighting it to the point where it's now causing me to have headaches and fever and shakes and chills, and I am maybe even seeing some problems with my neural problems where I can't smell or taste as well as I used to, or I might have some other vascular or neural problems where my toes are turning blue. Those are going to take some time to observe. So we're not going to see those in the first few weeks, or the first few days, and certainly not in the first, 1 to 3 days before symptoms. But you can detect the virus. The virus is there. I've been exposed. The virus is there, but it's not being spread from person to person yet. Viable virus has been isolated from asymptomatic people, though. I don't have to have symptoms for you to observe the virus in my nasal cavities or in my sputum or in feces. And for those with moderate or higher disease, we might see up to 3 weeks and longer. For those with severe disease, the virus still being found in my bodily substances. Active virus is typically not detected by nasopharyngeal testing beyond 8 to 10 days after symptom onset. So we're getting an idea that this is a very small window where you're going to be able to pick up the signs of the disease before I'm really quite infectious to other people. And I may not ever have any signs and symptoms of the disease. And in fact, even long after the symptoms resolve, I still may have virus shedding from me, which would be infectious to other people. So those are some concerns that we have. So we talked about the agent itself and the reservoir of our bodies. Once we look at those links, then we might consider how we might interfere with the portal of exit. So that means that now that if I was exposed and there was an incubation period and the virus was replicating in me, it has to find a way to get out. And one of the brilliant things about viruses is that viruses cause you to sneeze and cough, more, it causes you to have more mucus, and all of those things affect the portal of exit. So how could we reduce the opportunity to infect others? We want to distance ourselves from other people. If there's a pandemic, we want to distance ourselves whether we're sick or not. If there isn't, or in any time, we want to obviously try and stay home if we're sick, because we don't want to be spreading any virus around. And we need to get tested if we have symptoms. So if you are able to, and whatever the process is where you're at, to access help to get tested when you have symptoms, that would be important. And when you're in close proximity with other people, do the best you can to not be a spreader. So use whatever PPE is recommended, if it's masks, goggles, and wash your hands, and maybe don't engage in some of the higher risk activities like shouting or singing, which are higher risk activities for spreading disease. So we also want to encourage people to be careful with things like sneezing and coughing. We want to ask people not to leave dirty tissues lying around or stuff dirty tissues in their wrist of their clothing. We want to ask people to be very careful about the things that they do for shouting or singing or cheering. And also, if people have diarrhea, they should be staying home, because diarrhea can also aerosolize diseases we'll talk about in a bit. We want to also stop germs from leaving reservoirs by wearing masks and using cough suppressants. So even people that have said to me, oh, well, it's just allergies, or, oh, it's just this other problem that I have. I'm a smoker, or whatever else. That's why I cough. Well, I really don't care. I mean, it doesn't matter why you're coughing. Coughing is causing virus to be forcibly expelled from the person. So we don't want people coughing for whatever reason. We want people to cover sneezes and throw away any used tissue and then wash their hands. We want people to stay home if they're sick and not to go around touching things unnecessarily. One thing people maybe don't realize is that toilets can sneeze. So especially if you're in a public toilet, and oftentimes people have the pressure turned up on public toilets so they don't have to use a lot of plunging and calling in of services. But we've all seen toilets actually kind of spew droplets of water. Sometimes you'll see droplets of water on the seat. And the reason for this is that the toilet actually does aerosolize. So if somebody has COVID and they are in the washroom and they flush the toilet, then some of those virus particles could be aerosolized into the air through the flushing of the toilet. So we want to have lids on our toilets, and we want to close those lids. And I know that's difficult in churches because sometimes we just don't have that. And also people want to limit the touching of the lid and all of that stuff. But we can wash our hands afterwards. We can't really do much about breathing in viral particles if people are using public toilets and then flushing them in our presence. So the next step in the chain of infection is the mode of transmission. Viruses are by nature really good at exiting sick people. So even though we talk about them as if they're clever, they're not. Viruses are non-living, and we really are talking about whether they can be activated or inactivated, but they can absolutely be spread by these things that you see here: by breathing and talking, laughing and singing and yelling, by saliva, through sex, through coughing, sneezing, and defecating. So viruses, again, are excellent at moving from one person to another and have many ways of doing so. So when we talk about transmission, there are 3 different kinds of transmission that viruses can move through, but respiratory viruses can move through. One of them is contact transmission. And what that means is that germs are coughed or sneezed directly on someone's hands, and or they could directly cough and sneeze onto an object, and then another person comes along and touches that object and then touches their face, and then they can receive that virus that way. So that would be called contact transmission, and that's when we're concerned about the things people touch. In the case of SARS-CoV-2, we're not as concerned about that as some of the other ways of getting the virus. It's been estimated that about 10% of all of the viral transmission has been transmitted by contact transmission, and the majority has actually been droplet Droplet transmission means that the droplets are spewed out of an infected person, and because of their weight, which is around 5 microns, they don't stay in the air very long. They drop. Droplets. And they land on surfaces, possibly like human skin or lips or eyes. And unfortunately, with the case of a respiratory infectious disease, they also are usually quite mucousy. So the person has mucus all along the respiratory tract, and as that liquid comes out of them, it also has mucus around it, which can break into smaller droplets and cause those droplets to stay in the air a little bit longer. Sneezes contain about 40,000 droplets and coughs about 3,000. But of course, we all know that the number of droplets varies according to the person. We've all had moist speakers talking close to us, getting drops on our face, so that's annoying. But they just happen to have a lot of saliva, or they happen to have some problems that are causing mucus in their upper respiratory tract. And other things that may influence the number and size of droplets is things like temperature, light, airflow in the room, and the environmental humidity. And the reason for this is that soon after those droplets leave the human body, they start to evaporate and they start losing mass. So as the largest droplets are going to come out of you, they're going to probably fall fairly close to you, but smaller droplets, like those after a sneeze, can travel far. So we say that a sneeze may allow a droplet to go as far as 6 meters, and that's about 20 feet. And after a cough, it can go around 2 meters or around, 6 foot 7 inches, or a meter or 3 feet 4 inches just from normal breathing. So what does that tell us? It tells us that we have to be very careful around coughing and sneezing, because those droplets are going to be expelled and go far. And then they can also then, as they dry, depending on the heat, humidity, and light, and ventilation, and some other things, they can sit in the air for some time. So when a person breathes in, you're going to inhale from a pocket of air that's about 15 centimeters tall. So if you took a ruler and you broke it in half, then that's about the length of air that we breathe in. And that position of that air is about 2/3 of the way down from your mouth. 2/3 of the way, 2/3 of the ruler would be below your mouth, and 1/3 of the ruler would be above your mouth. And that's the space that we're breathing in from. So you can see in this diagram that if somebody has COVID and they're spewing virus particles in droplets, the person who's within 1 meter would be breathing in those droplets and potentially the virus, and potentially getting sick. One of the things, though, besides contact transmission and droplet transmission that we're concerned about is aerosol or airborne transmission. Because what happens is that there are little aerosols of particles that suspend in the air. So when humans are ill, as I mentioned, there's these sheets and strands of liquefied mucus across their airways. So the mucus is forming because they're unwell, and then little bubbles come up with the vibration of your speech. So if you're yelling or cheering or singing, you find that more, and you know this. If you've been to a game, or if you're singing a lot at church and you're very exuberant, you can feel that little bits of mucus kind of releasing in there. And so the airflow breaks apart those sheets of mucus, just like blowing a soap bubble. And then those soap bubbles float out into the air. I was reminded of this at the beach the other day. I was with my family, and there was another family there, and they were blowing bubbles. And I was so happy to see them blowing these lovely bubbles. And I thought, what a fun thing. But the bubbles actually were coming over to us and then popping right near us. And I thought, oh dear, no, we can't have that. So I did actually have to go over and speak to them, because I thought, oh yeah, no, we don't want little bubbles of air, even inside soap, coming and bursting in front of us. So when we're trying to social distance or physical distance. So with SARS-CoV-2, the virus itself is very light. It can stay suspended in air. And you know this from when you've been at the movie theater and you've looked up. You can see the tiny, tiny little dust particles in the column of light that's coming from the projector. And those tiny little dust particles are huge compared to the virus. So you can imagine if those dust particles can ride in the air, so can the virus. Now, traditionally, there was some thought originally that maybe respiratory diseases were only spread by viruses and those nice big drops that have only a short lifetime in the air. But the WHO has reported that SARS-CoV-2 is primarily with respiratory droplets and contact roots, but normal breathing and talking can result in aerosols. So there has been some experimental studies done, and in these cases, which were, of course, in a lab and looking at this in a more medical way, but they were able to identify aerosols of SARS-CoV-2 that were viable, that lasted at least 3 hours. So we do need to be concerned about that. If you're in a situation where there is not a lot of movement of air in a room, you're going to have little clouds of mucus and virus hanging around, which is kind of gross anyway. So we want to increase our ventilation. We want to make sure that the air is cleaned out and we get nice fresh air from the outside and blow out all that human air from the inside. Now you might say that there are other airborne viruses like the one that causes measles, and that's absolutely true. We know lots about measles. We know a lot more than we do about COVID or SARS-CoV-2. We know that measles can absolutely remain infectious for 2 hours or more in the air after an infected person has coughed or sneezed, and just breathing in the contaminated air of somebody with measles will cause an infection. In fact, 90% of susceptible people close to a person with measles will become infected. So if you weren't vaccinated and you'd never had measles, and somebody came and you sat in a room with them for, I don't know, I'm going to give it an hour. We've certainly seen this in the movies, that there has been an infected person walks into a movie theater. So maybe 2 hours, you'll find that 90% of the people that are close enough to breathe in the air that they are breathing out will be infected. So we're learning more all the time about SARS-CoV-2, and that will help us to prevent more cases. So we talked about the infectious agent in the chain of infection. We talked about the susceptible reservoir and the portal of exit and the mode of transmission. So now we need to think about, how does the portal of entry play in this, and how can we interfere with that? So the portal of entry would be, now that that virus is out there, how does it physically get into the non-infected person's body? Well, normally it's about breathing it in. So a person who's infected with a virus could shed up to 100 billion viral particles during the course of their illness. So how much virus you inhale in the initial dose and the amount of virus that the person has in their body at any given time will indicate for us how severe the viral disease might be. So it's important, if the person is a super shedder and they're going around shedding tons and tons of virus, we want to identify those people and ask them to stay home and stay away from other people. But it's very hard. It's not anyone's fault if they're unaware. A lot of asymptomatic people or people with very mild symptoms in the community, and they are shedding up to 100 billion viral particles. And most of those viral particles are not, they're just nonsense. But obviously there's a significant number with SARS-CoV-2 that can infect people. So one of the things that we ask people to do is wear a mask. So you don't wear a mask to protect yourself, you wear a mask to protect other people. And why I say this is because one of the things that we're going to be looking at is, if you are infected and you don't know it and you're out in public and you're within that 2-meter zone and you end up breathing, coughing, singing, sneezing, any of these things, cheering, you will have a much less chance of being able to project those viruses in a way that will be floating around in the air like we talked about. So we want to avoid that. So most of the virus then will end up on the mask. What you need to remember, though, is that these masks then become filters. So don't then take it and stick it in your pocket once you've used it, because it's now full of virus, hopefully, if it's done its job both on the inside and the outside. So we want to be very careful about how we keep our masks, right? So some people change their mask and wash them after every time they take them off. And that's actually probably good practice. If you can't do that for whatever reason, though, it's good to have a paper bag or a Tupperware container or somewhere that you're keeping that mask so that it isn't getting dirty and causing you more problems. So make sure that your mask fits snugly. A, make sure it's clean. B, make sure it fits snugly around your face. And so little gaps let the air and respiratory drops leak in and out around the edges of the mask. So pick one with layers to keep the respiratory droplets in. And choose a mask with a nose wire so it can actually go fit nicely around your face. And then bend that nose wire over your nose to fit closely. And obviously change your mask whenever you've touched it with unclean hands, or if you sneezed, or it becomes wet. So masks are not 100% protective at keeping transmission down in your church. They're not, but they can help. One of the things that I like to think of is I call it the Swiss cheese method of public health. And what that means is that although the things that we're doing are not 100% protective, they are partially protective. We could look at this with car crashes. We could say, look, it's not that wearing a seatbelt is the only thing that stops you from a head injury while traveling in a vehicle. It's one thing. But speed and not driving well under the influence and having graduated licenses, we could name 100 things that we could do that would improve your chances of not having a head injury when you're traveling in a vehicle. But that doesn't mean we don't do seatbelts, right? So it's a part of the picture. So it's like that with the Swiss cheese method can be looked at with car crashes. It can also be looked at with preventing a respiratory infectious disease. So if we physically distance, we can reduce transmission by about 10%. If we wear eye protection, another 10%. Wearing a mask, about 14%. We don't have good details on hygiene just because it's difficult to nail down, but we know that good hygiene reduces the reservoir, and so logically we know it prevents. We can look at things like nasal sprays with iodine. We can look at screening for symptoms and point-of-care screening by increasing ventilation. All of these things add protection. They add a little bit, add a little bit, add a little bit. And so if we only had one intervention, if we only wore masks but we did everything else, we would still have a lot of holes in our public health program to prevent transmission in our churches. If we did 2, we'd have better. 3, better. 4, better. So you can see as you add layers of those pieces of Swiss cheese, eventually it's going to be very hard for a virus to get through, but it's the combination of all of those interventions that helps, and not just one individual intervention. So we've talked about the agent, the susceptible reservoir, the portal of exit, the mode of transmission, the portal of entry, and finally we're on to the susceptible host. So in order for somebody to become infected, they have to be susceptible. So what makes someone susceptible? Well, some of it you can't change, right? So it might be your age or your sex. It might be your ethnicity, but it could be things that you might be able to do something about, like stress and habits and hygiene. And so we want to be thinking about how we can, shore up ourselves, make ourselves more healthy and resilient in general, which will then help us to be less susceptible to any infectious disease or any disease in general. So is it all about chronological age? We talk a lot about that with COVID, but actually, yeah, but there's a difference between your chronological age and your COVID age. And if you're interested, you can take this assessment tool and just type this or cut and paste it into your browser, and you'll be able to find out what your age is according to COVID. So I did a couple just to give you an example. If you want to pause it here, you're welcome to look at that more. What can generally reduce the spread of infectious diseases, though, if we're actually looking at the susceptible person? What do we want to do? We want to include things like hygiene and cleaning. If we keep clean, especially our hands, and we clean and disinfect high-touch surfaces, we're going to reduce the chances of transmission. If we use PPE, as we talked about, which could be masks and gloves and goggles, it could be aprons in our churches, and if you have your staff or you do the session on cleaning, the module on cleaning that I have, you'll see that I talk a lot about those. Ventilation, making the air that you're breathing cleaner. And that might be by looking at your HVAC and make sure it's not recycling air. It could be opening windows and doors, or it could be using strategically placed fans. So those are all things to think about. There's also duration and distance of how close we are to people and how long we're in their presence. And then, of course, what we're doing there. Are we singing? Are we shouting? Are we cheering? Are we speaking? What are we doing in their presence? It's also about having clear policies and procedures. So churches are places that employ people often, so you have staff to be concerned about and the rules and policies around employees. There's also policies and procedures that one could look at, and we'll talk a little bit about that later, about how to improve your infectious disease control and reduce transmission. And we can put up barriers. It's funny, I mean, with churches, we always think like our main thing is to reduce barriers between people, anybody, and the Lord. That is our goal. We want to reduce any barrier between people and the Lord so that they can find Him and find life and joy and freedom. So it's awful that we have to be talking about churches and talking about barriers. But what I mean by this is things like if you have a reception area, yeah, maybe we can put up a glass barrier between people and the workers. It could be about encouraging people to move through the church in a certain way by putting arrows on the ground and directing people, in one entrance and out one exit. So those are the kind of barriers we're talking about. But absolutely on a spiritual level, we want to be reducing barriers. So it's tough to talk about this stuff sometimes. One of the questions people have about testing, and I do promote testing, I do believe in testing, I think testing is good, but it's not perfect. And one of the reasons why I say that is because testing depends completely on timing. So I mentioned this before, and I'll just use this as a way to showing you what I'm talking about. So when you're initially exposed to the disease, you're going to have a very low level of virus. So in fact, 98% of positive cases are not going to be detected by a test in the first couple of days after being infected. However, during those first, say, 5 days, we're going to have some multiplication happening. And about 50% of positive cases will not be detected yet by test after those first 5 days. But you're incubating during those times. By days 4 to 8, you're going to start to get symptoms, and you're probably going to have more virus at that time. So this is a good thing. I mean, that's the best time to be testing people, is when they have a plentiful virus. And about 10% of positive cases won't be detected at that time, even when you are most plentifully shedding virus. So the best case scenario during those times, the timing is right, we're going to pick up about 90% of positive cases, and that's really good. So with the current tests that we have, it's a little bit difficult to pick up tests. And of course, beyond day 15, once you've been exposed and you're recovering, there's a very low chance that we're going to be able to pick up a positive test at that time. So testing too early won't pick up positives, right? So you have to wait to about 4 to 8 days after exposure. And then testing too late is also not going to help. So we've got a real timing problem when it comes to testing. So I think testing is great. Testing was meant to be diagnostic. And what I mean by that is that somebody comes in and they're sick, and the doctor wonders, what course of treatment should I use? So she asks the person to be diagnosed with the test, and the test comes back, and then they choose a course of treatment. That's the purpose of diagnostic testing. However, when we're talking about this kind of test, we're actually talking about screening. And screening is when you say, gee, I wonder who in the population is positive. Let's go find out. So we want to screen for who is shedding virus in our church. We have to be very careful about the timing. So timing is everything. Now you could do a test and make sure that as you're testing that you're trying to pick up nasal swabs and you're putting that in somebody's nose and finding out, the question then would be, is there virus in this nasal swab? Actually, the tests are pretty good at telling you that. Yeah or no, yes or no, there is and there isn't. But what they're not really good at saying is this person infected with COVID? So that's the difference between screening and diagnosing. So for our purposes in the church, we don't want to diagnose anybody. That's not our job. We're not hospitals. But we may want to do some screening. And what I mean by that is we may want to test people to find out if they're currently shedding virus. So you could go out and get some antigen tests, or you can ask people to do antigen testing at home and do a test and find out if they're shedding, and then they can come into the church a little more confident than they did before. So that's what that's about. It's really important to write policies and procedures that are going to help to communicate to everybody what it is that they ought to be doing. So everybody in the church can have access to your respiratory infectious control plan. They can see what it is that you have planned for them in order to keep them safer. It increases confidence that yeah, wait a minute now, my church cares about me and they care about my safety. It increases confidence for the community when they look and they say, wow, look at this church. They really care about health and safety and wellness. And it communicates something to the government too, to say, we're serious about this. We've taken the time to write really good policies and to make sure that people are adhering to things that are safe and good and healthy and promote wellness. And so these are the different policies you may want to have, and others. So you may want to consider going through the module that I've written on writing policies and procedures for churches that will help you to write good policies that are appropriate to your church, and then also figure out how you're going to do the things that you've set out to do. So there, have a look at that module, and it'll help you to write some good policies and use the right language in order to communicate appropriately what it is you want to do. And it's your choice, right? Oh, unless you're under the authority of the government to do specific things. But normally we have a lot of freedom and choice in what it is we want to do to make our community safer. So what does all of this mean for the church? There are a number of ways that church leaders can reduce the likelihood of disease transmission in their churches. So by understanding how the virus works, you can be inspired to improve cleaning, to increase air exchange and ventilation, to decrease the density and duration of exposure, to reduce the number of objects shared between people, to encourage safer behavior. So there's lots of things that you can do in your church to help to make it a safer place that is really a promoter of wellness and health. So let's do a little case study here and find out how can this be carried out in the church. So let's look at Central Church. So Central Church is a caring church that has a place for everyone. The doors are open to people from all over Central City. And alongside their full to capacity Sunday services, there are weekly Bible studies and small groups and choir practices and committees, outreach events, and more. So busy place. So Central Church is a great place to be. So let's meet Jessica. Jessica is the Youth and Children's Coordinator at Central Church. Normally she organizes great events for the kids from all over the city. And now that we have the pandemic, the church was shut for a few months, but she's being asked to start things back up. So Jessica wants to know a few things before she invites groups of kids back to the church. The first thing she wants to figure out is what is the risk of the population that she's working with. It depends on the age of the kids. It depends on the variant that is circulating in that community. It depends on what kids are doing. You know, if kids are already going to school and preschool and playing at parks and water parks and everything else, then, you know, is this a risky activity compared to the other things that they're engaging in? And are the kids exposed in a high way to lots of other things? She also wants to know if the youth and children are having severe infections of whatever the pathogen is. And who do they interact with? Are they likely to abide by prevention protocols? Do you think the kids are going to wear masks? Are they going to wash their hands? Are they going to stay away from each other? You know, realistically, we have to think about these things. And will I need to do some kind of training, right? And will kids understand what it is that they're being asked to do? So Jessica sends an email out to the parents explaining that the church has decided to restart the children's programs. And she sends a coloring page for the kids on the new ways of being together. She also contacts the youth and invites them to a Zoom meeting to meet together and discuss new ways of being safe in each other's presence. So Jessica continues to assess her situation, and she remembers how diseases transmits. She wonders what all she can do to stop and reduce the spread of disease during her ministry time with the children and youth. So I want you to pause the video here and think through, what is the agent in this case? What's the reservoir? What is the potential portals of exit? What are the modes of transmission? What are the portals of entry? And who's the susceptible host? So pause the video here. These are the answers that I came up with. They may be the same or different from yours. You may have come up with some better ones. So you can pause it here if you want to read what it is that I came up with. So what should Jessica and the other church leadership consider? They should prayerfully consider the reopening of the kids' ministry. They should communicate the risk with family and kids, whatever is appropriate to the age of the kids. They are prepared to dial back the situation if anything changes. They're going to screen for symptoms and vulnerability. That could mean using point of care testing, like reagent testing. It could mean asking about symptoms. It could be asking about who might be vulnerable. They limit the numbers and keep track of everyone involved in case of any kind of exposure. They provide hand sanitizer, increase hand washing. They might provide masks. They might provide tissues. They continue to watch the changing guidelines and make sure that they're really adhering to what's being told to them by public health authorities, which may be very hard sometimes, but it is for just a limited time. And they make sure that the environment is clean and well ventilated where the kids are. Here's where we got the information for these slides. Thank you so much for taking the time to make your church a safer place by understanding the basics of disease control.